Hi, my name is Claude Hemphill. I'm a neurointensivist and vascular neurologist at the University of California, San Francisco and Zuckerberg San Francisco General Hospital. And I'm going to speak about COVID-19. Is there an increased risk of stroke? We all know that COVID-19 and the pandemic is very much on our minds and an important aspect of the care we're providing across the spectrum of care now. And the question of whether there's an increased risk of stroke has come up and may drive the management decisions that we make for patients with neurological conditions. I have one conflict of interest, which is not relevant to this presentation. So this really came to light with a report in the New England Journal of Medicine back in May, where a group at Mount Sinai Hospital in New York reported 5 patients who were young, under the age of 50, who presented with LVO, large vessel occlusion, over a 2 week period, and they were all COVID 19 positive. Two of them had respiratory symptoms, one was lethargic, and two were asymptomatic. But this caught their attention, and they reported this small case series as really a question: is this a harbinger of things to come? Is COVID 19 causing strokes in young people? And is this going to really blow out of proportion here? Is this going to be a big deal? So, this raised a lot of concern and raised a lot of questions about whether stroke is going to be either impactful in COVID 19 or whether it's even going to be potentially a presenting symptom of COVID. Why would this even happen? Well, we know that hypercoagulable states are described in COVID 19, and the virus may directly invade endothelial cells, causing endothelial damage that could lead to thrombosis formation and then thrombotic stroke or embolism. There is a slightly prolonged prothrombin time and thrombocytopenia, elevated D dimer, circulating pro inflammatory cytokines. And there's a question about whether this may actually be just systemically, not just with stroke, a low graded DIC microthrombotic angiopathy. So there seems to be some biological plausibility. But when the report came out from Wuhan, where they looked at clinical characteristics of patients with COVID 19 who had neurological symptoms, what they found is that among the neurological symptoms, stroke was pretty uncommon. 2.8% overall had stroke. Most of the neurological symptoms were things like dizziness, encephalopathy, and so forth. Stroke is not common, but they did find that it was seen more often with severe COVID. So this opened up a whole series of case reports, and we've seen a lot of case reports, and that's happened in the pandemic across diseases, not just stroke or neurological diseases, where folks have reported there's a case here of ischemic stroke with LVO or lacunar infarction, intracerebral hemorrhage, cerebral venous sinus thrombosis. And the questions come up: is this a cause? Is this an effect of COVID? Is it just true, and unrelated? We've got patients with stroke who have COVID and vice versa. So, another series from Italy and from the Netherlands, when they looked at patients who were hospitalized with COVID or even in the ICU with COVID, about 2% of them had stroke, primarily ischemic stroke. But we can say that even if the incidence of stroke is low, high COVID infection rates should lead to higher numbers of stroke cases. And this editorial in the journal Stroke in July looked at the existing case uh, uh, cohort studies. They excluded case reports and case series and found that roughly maybe there's about a 1.5 to 2% rate of stroke in these cohort studies of COVID. So, what about stroke rates and outcome? So, now we've got a number of reports from different countries, sometimes with country registries or with single hospitals. And a report from Denmark looked across the country and found a drop in ischemic stroke and TIA hospital admission rates in the COVID pandemic. But there was no decrease in hemorrhagic stroke admission rate and no difference in overall stroke mortality. A single hospital in Germany reported a 20% decrease in overall stroke. And at the same time, they had a 41% decrease in acute coronary syndrome, but no decrease in intracerebral hemorrhage. And a multi-center group in Northwest Spain looked at perfusion therapies, and they found actually they were treating fewer patients, and there was an increase in door to needle time, an increase in time to treatment, in patients with acute ischemic stroke getting intravenous TPA. Kaiser System is a large health system in Northern California. Over 4 million people are covered. And this graph shows their stroke rate of stroke alerts. So this isn't stroke patients. These are stroke alerts in the emergency department where they're calling on alerts to say this is a possible stroke, they need evaluation. And what they found is that after lockdown and shelter in place, there was a dramatic drop in stroke alerts. And a higher percentage of their admitted patients had large vessel occlusions. And they actually had fewer stroke mimics presenting. Remember, stroke mimics are things like someone comes in, they think they have stroke symptoms, but they actually are just a migraine headache or perhaps a mild focal seizure, things that often aren't as severe. Now, here's Mount Sinai Hospital, though, in New York that had that initial New England Journal presentation or of case series. They actually did report a big spike in their number of cases. And so they really felt like they're seeing more cases and they're more LVOs. But a comprehensive stroke center in New Jersey didn't find this. They had no increase in the absolute number of LVO cases, but the percentage of stroke cases they were seeing in the hospital were more likely to be LVO. And interestingly, there's a software program called Rapid that's widely distributed across the US and maybe other parts of the world that's used to assess CT perfusion imaging as well as CT angiography. That was used in some of the extended window embolectomy trials, such as Dawn and Diffuse. And they showed this drop in the number of rapid cases that were done. This is sort of a centralized software system at the rapid headquarters. And they look at the number of cases that are from every rapid site. And they showed a big drop once cases were reported, and then certainly a drop as the statewide stay-at-home order happened in California. But then the cases started to rebound. What's going on here? How can stroke incidence be going up and going down at the same time? And this editorial in Stroke in July 2020 brought up the curious case of the missing strokes during the COVID-19 pandemic. And there's several factors likely concurrently at play. There's a large increase in COVID cases, we all know. And so there possibly is a small increase in stroke incidence with COVID-19, but we have all been concerned about a decrease in utilization of healthcare resources for non-COVID emergency conditions during this lockdown and shelter in place, or a delay in presenting for care due to COVID concerns. Some emergency conditions are just too severe to ignore, and massive stroke is probably one of these. If someone has a massive stroke, first of all, they're more likely to be LVO or hemorrhagic stroke, but also it's hard to not go to the hospital regardless of what's going on. But minor strokes are probably driving this decrease in stroke activations. The so-called concern for collateral damage of inadequate care for non-COVID conditions during the pandemic. So attention has been brought from organizations in the US and Europe regarding how to deal with this. And this is a report from the American Heart Association, where they focused on pre-hospital triage of acute stroke patients during the COVID-19 pandemic. And they emphasize integrated systems of care that can work at the pre-hospital level in order to get the patients to the right hospital based on their stroke symptoms, but also based on their potential respiratory symptoms and how that's managed based on hospital patient acuity, hospital volume, emergency department volume, transport times, and so forth. They emphasize these integrated systems of care and pre-hospital screening, concurrent management of the neurological and respiratory condition. And the European Stroke Organization has come out with their recommendations for maintaining stroke care in Europe during the pandemic. And they emphasize public education for seeking stroke care, protecting acute providers, issues of ensuring adequate PPE, personal protective equipment, and then tracking cases and outcome. And their biggest emphasis is that the general population should be informed that stroke is an emergency and treatment is still available. So you got to call emergency services and get to the hospital, but this is going to take public education campaigns. One thing I want to call your attention to is we're all asking the question about how frequent are various organ systems involved in COVID-19. And this is very important for the neurological central nervous system, peripheral nervous system. So there is a study ongoing called the GCS NeuroCOVID study, Global Consortium Study of Neurological Function in COVID-19. And this is just getting started. Sherry Chu is one of the principal investigators, along with Molly McNett. And Sherry is speaking on neurologic aspects of COVID in another talk in this session. And I would encourage you to consider being part of this. It's a collaborative study between the Neurocritical Care Society, the European Academy of Neurology, Latin American Brain Injury Consortium, the Possible Network in Latin America. And the hope is really to understand and track these patients in order to understand the scope of neurological dysfunction that does include but is not limited to stroke. So in conclusion, COVID-19 and stroke. What's going on? Well, an increase in the incidence of ischemic stroke due to the COVID-19 pandemic is biologically plausible. But the increase is quite small, probably. And stroke as a presenting symptom of symptomatic COVID is uncommon. The most significant impact of COVID-19 on stroke is likely due to changes in patterns of acute stroke evaluation, due to the lockdown and shelter in place, and patient fear of seeking care during the pandemic. So it's a major effort for public education and organization of systems of care is really important as we consider stroke and other non-COVID emergency conditions. There is a question, should ischemic stroke in the setting of COVID-19 be treated differently? As of now, there's no clear evidence yet to suggest so. One thing that's been brought up is, should patients who have stroke in the setting of COVID be anticoagulated if they don't have another indication like atrial fibrillation, so beyond just venous thromboembolism prophylaxis. And that remains to be seen, but hopefully studies like the GCS NeuroCOVID and other registries will inform us on this. Thank you very much.